absolutely delighted to welcome you all to the second of this 3-seminar series run by the National Institute of Health Research's ARCs. For anyone who's unfamiliar, the ARCs are applied research collaborations, a mixture of academics, researchers, clinicians, members of the public and practitioners coming together to work on some of the most pressing and challenging health issues that we have in place today. This series of 3 seminars focuses particularly on mental health, and today's seminar focuses on mental health and social inclusion. I'm delighted we have 3 brilliant speakers coming to give us just a flavour of some of the excellent research that's been happening across the ARCs on social inequalities. I would flag that we have both experienced and early career researchers presenting today, so please do demonstrate your engagement through the questions, but also practice kindness in the way that you approach them. So each speaker will speak for about 10 minutes, and we will have a 5-minute section after each speaker to pick up any immediate questions that come to mind. You should all have access to a Q&A box where you can see other people's questions, you can submit your own, and you can also see answers that might have already come through. I can see we've already had something come through that's been dealt with around recording and slides, which is fantastic. Please do submit your comments. If we don't get a chance to get through all the questions, hopefully we will have a little bit of time towards the end as well, but we'll make sure that we forward those to the speakers, and hopefully you'll have a chance to connect and catch up after the session. So without further ado then, we'll move on to our first speaker. So our first speaker is Professor Domenico Giacco. He's based in the ARC West Midlands, and he is their Deputy Lead for Integrated Care and Youth Mental Health. So I'll pass over to Domenico.
Thank you very much. Okay, so thanks for this invitation to talk about this work that we actually very recently completed, and that we carried out trying to improve mental health care for people from minority ethnic groups. So it's like the background to it is something that I think many of you are kind of quite aware of, the fact that in mental health care, some minority ethnic groups, they have worse experience of care, they have higher rates of treatment under the Mental Health Act, and in general, they have poorer access to care, poorer early access that sometimes results into kind of late access when people are quite unwell, and then when coercive treatments then need to be used, or acute treatment need to be used, which again contributes to a poorer experience of care then. This study was based on our collaboration, but it was in addition to that, it was funded by the NIHR Policy Research Program. This is disclaimer that the views are those of the team, not necessarily those of the NIHR or Department of Health and Social Care, and also I'm supported, as Professor Oliver was saying, by the ARC West Midlands. So just to start, is obviously I'm here presenting it, and I was sort of having a role in co-leading it with Professor Swaran Singh, but this is very much a joint effort of people from different ethnic and cultural background. Some of them will lived experience of both challenges of with severe mental health problems, and also sometimes bringing in experiences of discrimination or poor access to care or poor experience of care. So we had quite a large group of people, and we have tried to work with lived experience as much as possible, because it's quite key to this kind of research, we feel. And indeed, the methodology that we used is something called experience-based co-design. In this methodology, you start from interviewing a large group of people, in our case, 90 people. Then you do some focus group to try and select the key themes and issue. And then eventually you work in a series of workshops to try to develop actions that trying to improve those issues. And we did this kind of a methodology that you could see again kind of schematized here. And we did this methodology across 4 different sites: in Coventry, where I am now, in London, in Sheffield, and in Manchester. So the idea was to identify as much as possible local issues in a lot of depth, and then only at the end of it to draw general national conclusions. So we did these procedures with interviews, with focus groups, with workshops for each of the individual 4 sites, and then we draw conclusion at the end of it, because we felt there's a number of things that we can learn at the local level, and the national level would be too much of a generalization at the early stage. So obviously this study happened at a time in which COVID-19 pandemic happened as well. And the first question is, how has COVID changed things in this regard? And what we can see in this kind of slide is that there are continuing barriers in terms of individual barriers, that poor experience can generate mistrust of mental health services, cultural attribution models can be different, and there are some challenges about stigma as well. But in services, there's lots of barriers in terms of a monocultural Western model of mental health care and psychiatry that very often people from other cultures find it difficult to engage with. There is instances of racial prejudice and discrimination that of course, that's something that one has to think about and discuss. There are sometimes negative individual clinical encounters people have experienced, that maybe assessments not done well that have contributed to their own poor experience of care, and a general NHS landscape, which at the time during COVID was obviously under a lot of pressure. And the COVID-19 impacts, in a way, has made these things even more challenging, because the routine community mental health care was reduced. There were some heightened expectations, minority ethnic staff that some of them particularly at risk for COVID and its consequences. But very importantly, there was a closure of community organization, which is so important into generating that kind of trust and that kind of role of connection between the communities and the services. And there was at the time, if you remember during COVID, some scaremongering about how COVID might impact people from minority ethnic groups, particularly some minority ethnic groups, and we're talking about, for example, Chinese groups and so on. And there were also some positive developments, so people find the change in care more empowering, but these positive developments are probably just a part of people. Many people became more vulnerable because there was less services, there was less community organization, and there was a climate which was worsening the barriers which are already there before COVID. Now, we did work again at the local level, and we developed quite a large number of actions. I will not go into all the individual actions because it would probably take 30 minutes only to talk about them and to make kind of with any kind of detail. But I would like to pick out the 3 main themes on the national level that we found from the individual local actions. The first one, outreaching to communities, and very often this has to be done upstream, with young people working into school, working into community hubs. There needs to be some neutral community safe space. Sometimes institutional space is not the best time not the best kind of venue to engage people into mental health care. And obviously one has to think about different perspective about mental health care, and institution is part of it. And again, like the idea of developing a culturally sensitive network of care in which NHS works with different organizations that serve particular communities. The idea of diversifying the mental health care offer, and particularly thinking about incorporating people with lived experience, and also providing information on treatment, which are not only the pharmacological or acute one or hospital-based one, because very often if people have experience of those very acute treatments, they might generalize and think that all mental health care is like that, whilst obviously there are different options of receiving mental health care, which can be peer support based or community based or therapy based, that some people might sort of not necessarily be aware or be very engaged with for a number of reasons. And the final one is enabling open discussion on how ethnic groups have different views about mental health, different cultures, and the impact on this on how people want to engage with mental health support and help, and also on racism and discrimination. So it's important in the NHS, there is culture of openness and discussion, and obviously avoidance of instances of discrimination, but that patients can actually report and speak openly about this if they feel they have gone through this kind of very distressing experiences. Just to give you a small example of how in-depth we went into designing the actions, this is just one action about importance of lived experience. We work with the Warwick Business School to develop really in detail how the action should look like. For example, if we thought about what is already available that we can use to favorite importance of lived experience. If we were to advertise for other people who lived experience, how we do that, and obviously we don't do You don't necessarily do it through the NHS channels, but you could do it through radio, magazine, going into church, or going into community organizations. We thought about how the kind of supervision, what is the supervision that should be available to people who live experiencing services, and what are the things that might be attractive in terms of long-term contract, in terms of being aware of receiving support for someone's mental health if things are not going well or things are too stressful. So we went into an enormous amount of depth for each individual actions. And the interesting thing that it was the service users, the clinicians, and the carers were all there trying to define this kind of level. So it was a very interesting collaborative exercise. And I have these similar kind of actions for all the different 16 actions that were developed at the different sites. On the national level, in addition to the general theme that I just presented, the idea was also that in order to sustain the action, there needs to be a national hub. There needs to be a social movement to maintain this momentum in terms of reducing inequalities. And this national movement should be, in a way, really strongly represented in terms of user-led research and user-led advocacy. Now, to conclude, and this very kind of quick outline of the findings, first, some reflections in terms of research. Administrative hurdles, as I told you, there were peer researchers employed, and setting them up with peer supports and all the checks, it takes quite a long time in the current landscape. And when a project has tight timelines, that might mean that things are quite pressured, and in a way, it's not, sometimes can be an experience that needs to be managed for the peer researchers who obviously want to do research immediately, but obviously there is this kind of administrative barriers. And in terms instead of the relationship with the communities is something that's really important to foster for longer term. It takes time to develop relationships with community groups, to identify the right people to interview and so on. And hence it is quite important to keep the research momentum going even after a project is finished. In terms of reach, we felt we had a good kind of presence with Black and South Asian groups. We had less we interviewed less people from other groups, like, for example, the Chinese group or others. And so that's sort of an area that we feel we should do a bit more, try to understand how to involve some ethnic groups in research. Also, we focused on urban settings in which which are more ethnically diverse, but it might be that there's something specific to people from minority ethnic groups who live in rural settings, which we weren't able to find out. And again, the broader landscape, when you develop actions, obviously they are developed in a context, but both the NHS context and the societal context change very rapidly. So it's important to keep an eye on that. I've just the last slide with a few conclusions. The first one is the COVID-19 pandemic might have, in a way, what we heard from our qualitative work, it might have made worse usual problems. And this impact may be long lasting, might be way longer than the COVID-19 pandemic. And also it is something that seems to happen whenever. So this is more of a natural experiment for when community services and initiatives are reduced. When community service initiatives are reduced, many minority ethnic groups will suffer. The actions that service user and our clinicians, that our co-production works develop, seems to be fit very well with the ethos of integrated care systems. So there's an opportunity there now to try and put this action in practice. And our action plans, the real idea of this project is go from the theory, from the experiences to action. But we feel that in addition to these kind of action plans, we did the continuing national movement, and then very welcome the opportunity to present in this context, because I think this is one of the time in which we can start this kind of conversation or continue this conversation trying to reduce inequalities. Thank you very much. I think that was the last one. I hope I didn't go much over the time.
That was great. Thanks, Domenico. Really, really impressive program of work and lots of different strands. You can tell that a lot of thought's gone into the ways of going about trying to do this work. We've had an interesting question come through. I guess a lot of some of the issues of working for and with our communities are around trust. I wonder if you could talk us through how trust in Western medicine in particular might have been gained in some of the communities that you've sought to reach.
Well, I think it's the trust in Western medicine. I think we have to, there needs to be, again, even then a co-production. I think there is we cannot necessarily go ahead with a monocultural model. The care that we provide needs to be aware of the people that we serve. So whilst there needs to be a conversation in terms of usual model is psychoeducation, trying to understand where we come from in terms of the way we look at mental health problems, we also need to understand how people from different cultures see mental health problems and trying to have some kind of integration. So yes, I think the conversation needs to be there rather than just one kind of culture dominating the other, I feel.
Fantastic. We've had another two interrelated questions, really. You mentioned that, I think, early on that some of this work was with the Policy Research Unit, and these are kind of, I guess, policy related questions.
No, there was the funder is the Policy Research.
I see. Okay.
Sorry. Yeah.
So the questions that have come through is, how does what you've done in that region translate to potentially influencing change at a national level? And have you had any involvement in the patient and carer race equality framework?
Well, we had, yes, like we did. We sort of framed some of the actions according to that framework. Also, Steve Gilbert, who's been instrumental in the patient and care equality group, the race equality kind of framework, it was part of our team. And yes, like the idea is that obviously that was one of the framework that we looked at when we framed the actions. And the whole idea is to go from the 4 different local sites to something that can be national. And I mean, I guess these 4 sites, they do stand for contexts which, whilst being urban, are different, like London, Sheffield, Coventry, and Manchester. So one could say that at least on an urban level, we have sort of obtained a sample or a kind of group of actions which might apply nationally in a way, taking into account the context, but can be different. But yeah, I mean, it's obviously there would be the idea is that we will now disseminate and trying to continue this conversation and think about how these actions can be adapted to other similar but slightly different contexts, I suppose.
Perfect. I think that's so important, and events like today, I guess, are part of sharing that work with a broader audience. I think we've got time for one more question now. So there was a follow-up question to your point that you had some challenges in reaching Chinese populations in particular. Do you have any reflections on why that might have been?
Well, my understanding of the current evidence that they are kind of a group of people who are quite like a group of an ethnic group who are difficult to reach in research, probably because there is a lack of understanding on our side on how to reach them. So I think if I had normally I like to do kind of trying research like in Ariadne, we went for a quite broad definition of minority ethnic groups. But if it was one of the groups, and there are others really, but one of the groups that I would really think probably there is a need for a specific research project is try to understand how to interact with those particular minority ethnic groups and trying to, and again, also in that case, I believe that the cultural models may be something that we have to understand a bit more to be able to involve people in research. Yeah.
Perfect, thank you. There's some interesting follow-up questions which I'll leave it for you to have a look at after this, around whether we need to tailor strategies for different communities, and also the importance of working with parents when we're looking at young people in particular. So thank you very much for that, and thank you to the audience for your questions. We'll move on to our second speaker now. We have Dr. Patrick Nicara-Veranda. He's based in the in Sussex ARC, and he'll be talking about care pathways in mental health for newcomer populations, and I'll let him explain what we mean by that.
Thank you very much. Yes, so I'm here to talk about my PhD project, which I've had a lot of learning to do. And just a disclaimer, the last time I gave a talk around my PhD project, I spoke to the audience to say to them that I'll give them a lesson in anger. And unfortunately or fortunately, as a result, there were quite a lot of angry people at the end of my talk, and mainly because of some of the things I highlighted around female migrant mental health. So today I would like to continue that discussion, but more around a lesson in reflecting. So at the end of the talk, I hope at least you can reflect on some of the topics that we've covered today. So just a bit of background, we did a systematic review as a team. You can see my co-authors, and it was looking at the barriers and facilitators to seeking and accessing mental health support for female migrants in Europe. And one of the things that stuck out of that review was that there was a lot of mention around stigma, but not exactly what stigma was or in which aspects it was as well. And then there were issues specific to, specifically gender-related issues that were not touched on in some papers, but also the fact that there was also like scarcity of female voices being heard. So as a result of that, one of the recommendations we made from that paper was to look at specific female migrant mental health issues in terms of the broader barriers and facilitators, but also around the experiences, but also bring all that together through a co-produced study involving female migrants and those supporting female migrants. And so, as I said, around the co-produced aspects, we needed to actually have a group that had a specific purpose. And these are some of the reasons why they were chosen. But also, I think the last second point around a reference point for the study, especially around gender-specific issues, and considering that the lead researcher was actually a male researcher myself. So it was really important to have that group as a reference point for the study. And so what was the study? It was, we looked at, again, experiences and perceptions of mental health across Kent, Surrey, and Sussex. And just to mention, my study team involves academic researchers, but as well as members from the community, as well as projects that are actually helping female migrants as well. So we wanted to understand the barriers and facilitators, and that's what I'm going to be talking about today. We spoke broadly about a lot of issues, but today it's just around the barriers and facilitators, and also just to highlight the benefit of having lived experience within research as well. So for those that are into methodologies, it was obviously a qualitative study. We interviewed female migrants, and we worked alongside community-led organizations across Kent, Surrey, and Sussex. And this was really, really quite important for the study, to involve the communities, to involve the people that were affected by these issues. And in terms of the participants, it was 8 adults that self-identified as being migrant and also as being females. And they came from different countries as far away as Brazil, Portugal, Spain, Uganda, Zimbabwe, Kenya, and Nigeria, and Ghana, and China. So we had a very, very broad mix of experiences, as well as from different regions. And also, I must say, from Iran and Lebanon, and also from Iraq as well. So it was quite a huge number of individuals that decided to participate. We had an issue because we had so much interest in the study, but unfortunately we had ended up identifying just 18 to interview. And so that is one thing I would say, that there is quite an interest for participation with these studies. And just running quickly, we identified some barriers. Some of you, or all of you, will be aware of these barriers, including language problems and inadequate support for interpretation, not only finding it difficult to access interpretation services, but also some of the quality around interpretation was actually quite an issue. And in terms of one thing that was spoken about quite a lot, 3 words that were used in different forms, but meaning the same things, were around safety, security, and trust. Those words kept on coming over and over again. And the participants viewed that as something that was a barrier if they were not existing. So this is quite obvious around the waiting times, as well as stigma, which today I will talk about more than any of these barriers. And there was also things around fears of losing one's child if they disclosed that they had a mental health condition. This was quite common as well. And for those that were in either full-time employment or had family commitments, they felt that these were an issue when it came to them accessing support. And one of the things that was studies that we looked at in the systematic review almost like brushed aside were female-specific barriers, and our participants spoke a lot around issues concerning the period, for example, or going through the menopause as something that was actually a barrier, but something that didn't know how to address or to talk about as well. So this was really quite important. But like I said, I would like to stick more around stigma as a cross-cutting barrier, because it seemed that it was quite evident elsewhere, the stigma of having a mental health illness, the stigma of being female, the stigma of being a migrant as well. And so these are some of the sub-themes, but then, like I said, they were cross-cutting. And so I mentioned around one participant, actually quite a few, that spoke about having the experience or even the fear that if I were to disclose my mental health condition, I would get my kids taken away from me, or the school will actually make it impossible for me to see my kids through social services. So if there was a recommendation, it was probably more to do with actually having a greater awareness of what social services are really, because there was a lack of awareness around that. And racism was quite evident for a lot of them. And I think one Chinese participant in particular experienced quite a lot of racism through institutional settings. And she said that she actually found it difficult to, and worked even more harder to actually get the same support as was being offered for any other person. And when I said any other person, they said anyone apart from being a female and being a migrant. So this was quite an issue. And so society in general, and I'm including family and friends, there was the stigma of mental illness. So one family couldn't talk about them going through issues because obviously they were scared that, well, if we do talk about it, you are not going to get married. So again, those attitudes were really quite strong throughout the interviews. But it's not all doom and gloom. There were facilitators, and physical activities and things such as swimming and taking walks were seen as something that would improve mental health. And going back to those three things around safety and security and trust. So it's around finding these spaces where actually people could actually feel safe enough to do so. And music came as a big surprise to me as something that was good for mental health. So now I've got a very huge playlist of mine from songs that were recommended. And one good thing, and another thing that I found was different from the studies, was that faith and religious leaders were actually seen as positive and knowledgeable around mental health. So meaning that there's actually a need for us to re-engage with the faith and religious communities around mental health, because they seem willing and knowledgeable as well. And interpersonal levels, social networks, specifically husbands for those that were married, or boyfriends, and children were really, really supportive. But then also in the systems level, education and work-based support was something that was missing from the other studies, but this was something that was heavily, heavily talked about within our study, and for those that were in employment or within education as well. And as been mentioned earlier on, as an impact of COVID, online information was seen as supportive, as well as therapies that were conducted in person or online as well. So just to conclude, before I even put on my recommendations, this study has actually shown that we can work together with communities and with female migrants to actually come up with the questions and the answers, and also some of the probably solutions to some of these issues. But I wanted to say that female migrants are a specific population with specific needs, so that you can't generalize their needs to the whole population as well. And let's be aware of stigma. Just the recommendations. I had so many recommendations, but these are just some of the few that I will share with you today. And it's around obviously provision of information and education specific for female migrants, and also improving the access and knowledge and awareness really around school-based and work-based support, and adaptive support, which is not just culturally appropriate or aware, but also culturally curious as well. And there was a lot of talk around informal support. So that is something that perhaps can be done. Walks were seen to be something that was really, really welcome for that. And just lastly, just want to thank my community partners and those that have supported me emotionally and practically. And those are the Refugee Buddy Projects, Ethnic Minorities in Canterbury, the Finch Study, and Kent Refugee Action Network, and obviously Diversity Resource International. And thank you so much for that. Brilliant.
Thank you, Patrick. I think we've got time for a couple of questions, so I'm going to attempt to combine some of the ones that have come through. So I know you mentioned that you worked a lot with these community organisations. Could you just tell us a little bit more about how you went about recruiting participants, and also how you defined migrant?
Well, I'll start off with defining migrant. So anyone that wasn't born in the UK, that was my working definition. And in terms of how they identify themselves, I guess that was why I said it was important for them to self-identify as such. So, and in terms of how I went working with the community organizations, I took a lot of my time in terms of preparation, getting to know the community organizations. So I volunteered for them. I gave talks when I was invited to, and I also, I think, worked with them in terms of some opportunities that I was aware for them to engage or even to get funded for. So it was more like, I am one of you and I'm going to work with you. So it's just, I was in the community. That's what I would say.
That's fantastic. I think it also speaks to making sure that we're properly giving back in ways that are meaningful to the groups that are helping our research. One more interesting kind of set of questions, I guess. In fact, a question about whether the role of religious beliefs came up in terms of barriers, and also whether music was linked to feelings of identity and culture around well-being. Did any of those themes come up in your work?
They did. Actually, I've got 2 papers that I'm actually preparing on that, on music and also the role of religion and faith beliefs. So faith was seen as much, and religious activities were seen as social and therapeutic. However, at times it was seen as a barrier because, you know, in social situations, people can be judgmental. So there was that thing. But like I say, today I'd like to highlight the role of religious and faith leaders, because in our interviews, these were seen as very knowledgeable about the current issues around mental health. So they incorporated faith-based support, but also, you know, recommending that you see a professional. But in terms of music, like I said, I've got a very, very long playlist now, and it's I was surprised. Like, it was from jazz to hip hop to world music to samba to, you know, just, it was varied, and it could be up tempo, it could be slow tempo, but it was just a varied form of music, and it helped people to cope. Especially one lady said, after a very long day and I've been stressed, the one thing I want to do is just get away in my mind. And music was that. And there was a lot of dancing. I didn't realize that a lot of people dance. So I'm taking up dancing as well as a result.
Fantastic. That's great. And I look forward to hearing more about that in your paper as well. Thank you, Patrick.
Thank you.
There is one outstanding question, but I'll let you answer that on the chat after your talk. So we'll move over to our third and final speaker now. So Emma Adams is a doctoral fellow up in the Northeast and North Cumbria ARC, and she'll be presenting today about some of her co-produced work with homeless people around their experiences of accessing mental health support. So over to you, Emma. Slides are good.
Thanks, Emily. Hi, everyone. So I'm Emma, and I'm going to tell you a little bit about a study I led during the pandemic. But first, I thought it'd be nice to start out with a bit of a story. I want to tell you about Andy. In the beginning of 2020, Andy was living with his dad in council housing. When the initial lockdown started, he was pretty scared, but he knew everything was going to be okay because he had his dad there for support. Unfortunately, things took a turn for the worse when in the summer, Andy suddenly lost his dad. Before he knew it, he was kicked out of the place he'd called home. Andy had become homeless. He hopped from couch to couch and stayed with friends, but found himself in a hostel very quickly. He started to drink to cope with all of his grief and anxiety and just deal with living in a hostel, which wasn't like anything he could have expected. Unfortunately, Andy's story is all too common. And I think what's most scary about that is Andy didn't know where to go, to get access for support. And the question I always ask people is, would you know where to go in your time of need? We set out to really understand and explore how people accessed community mental health and substance use services in Newcastle and Gateshead. And we did that in the context of the pandemic. And the definition of homelessness I tend to use is really inclusive. So everything from people that we see on the streets, and also people that are in unstable accommodation or sofa surfing and staying with friends. So how did we do this? At a really high level, I spoke to 10 women and 16 men through telephone calls in 2021, just to understand their experiences accessing, or in a lot of cases, not accessing services. I worked with 5 people who had lived experience of homelessness, substance use, and or mental ill health to really just make sense of everything we were hearing. And we then embarked on this journey of a few different workshops over the space of 6 months to make sense of the data together. So what did we actually learn? There were 3 main themes, and I'm hoping to give you a bit of a flavor of them today, although I realize it won't be able to give you full justice. The first theme really highlighted this idea that often some of the reactive changes that were made during the pandemic led to people being excluded or left behind from services. The first sub-theme is what's currently illustrated by the quote on the screen. And I think what's highlighted here is this idea that often people felt like they couldn't access services when they needed them the most. And this was even more pronounced during the pandemic, when suddenly services that used to be available out of normal business hours were no longer present. And you can see this from this person sharing a really bad story where they said, sometimes you're feeling at your worst and it's late at night, you know, it's dark, and it's that when you feel you're most lonely, like after 10 o'clock at night and no one is actually around. The other 2 sub-themes sort of highlight other elements of exclusion. The second one is around digital exclusion. And with that, it was more than just not having the physical devices and equipment to access services online or remotely, but also understanding how to use those devices. So I think someone shared a really interesting story about getting a Zoom invite. And I think we all know what Zoom is. We're all on Zoom today, but they were told, oh, you'll get a Zoom call. They waited for their phone to ring, not realizing they had to connect through Zoom. The final sub-theme was just this awareness of what's supported out there. And I think that's one of the biggest forms of exclusion, of not knowing what you don't know. And people had different ways of finding out about services. And before COVID, a lot of it was word of mouth from friends or seeing flyers across the city. And suddenly that stopped when they were sort of forced to bunker down and stay in and keep where they were staying. The second theme is really on sort of those ideas around specific barriers when accessing services. The first one really picks up on this idea of the physical space in which services are provided. And I think this quote on the screen really illustrates that, where someone's talking about a treatment location and says it's not a nice place to go when you're trying to recover from drugs. They're trying to sell you things outside and inside the building, to be honest. And unfortunately, people had a lot of negative experiences with the physical spaces. People had ended up suggesting in a lot of cases that they needed a space that was reflective of their stage of recovery. And that meant they might need different spaces depending on where they were in their journey. The second sub-theme really picks up on this idea of disjointed care and constantly feeling like you're repeating the same thing over and over again to different service providers. And that probably wasn't something that's new during the pandemic. But the one thing that did come up that was interesting is in some cases, people found services worked better together and were a bit more integrated. So there was less of that repetition. The third sub-theme is this idea that for a lot of people, they're just not at a stage where mental health or substance use and drugs and alcohol is a priority. They have other more pressing concerns. And they found they were really frustrated when they were forced into services around their mental health or substance use when they weren't ready. And that led to them being disengaged from the service then, but less likely to get services later on. So there was a lot of conversation on how we could make that better for people. The final sub-theme was all around how we prioritize things and how we make sure services are available. So I think people recognize, there was just less services about during the pandemic, and what was available was operating at a smaller capacity. And we hear someone explaining, I run the crisis team a lot. I was on the phone to them 9 times in one night before they actually came out. He then later explained the crisis team is pretty much the wrong name for them, I would say. And I think he hit the nail with the hammer there, saying it wasn't what he thought it was going to be there. Realizing that was quite a lot of negativity, I thought that with the last theme, it's probably quite nice just to think about some of the more positives. So there was a lot of conversations that were really good about how services could be better and how we could create a system that's more useful for the people that are accessing it. So because there was a lot of disconnect between some of the services and the way they were delivered, what was delivered, and what people's actual need were, there was a large amount of interest in having lived experience and the voice of people who've gone through that services from the point of actually developing services to the point of then delivering them. And I think that's something that so many people would agree with. the sort of second thing was this idea around choice and active voice. And people recognized, you know, they couldn't always pick and choose what they wanted. It would be nice if they were at least asked for certain options. So the example I always give is, you know, if you were going to a coffee shop for a cup of coffee, and if I told you you could only have a black cup of coffee, if you don't like black coffee, that's probably not going to be great. If you don't mind it, that's going to be okay. And it's just about giving people a small choice of, would you like milk with that? Or would you like your appointment in the morning or the afternoon? So that was a lot of information to digest. And I don't think I could do it any justice in the space of 10 minutes. The question I ask is, why is this important and why does it matter? A lot of the information we found isn't specific to the pandemic, and there's a lot of things that could be learned that could apply now and apply before the pandemic and during the pandemic. And I think you can find out a lot more about that in our paper, but I also wanted to highlight 2 visuals we've created that are sort of co-produced and done in such a way to sort of illustrate our findings in a visual manner to make it more accessible. And these are available in hostels across Newcastle and Gateshead. So thank you so much. Hopefully that wasn't too far over on the 10 minutes. And if you have any questions, feel free to reach out.
Fantastic. Thanks, Emma. I'll give people time to drop their questions for you in the chat, but I have one for you to get you going, if that's all right. So you spoke a lot about how the work you did was co-produced and the brilliant illustrations at the end to summarize your findings. I was just wondering about how you supported people to engage in the co-production process. Perhaps you could talk us through that.
Definitely. So I guess I like to think of like co-production as something that's a bit of a journey, and that you never know what the end destination is going to be or how you're going to get there, and you figure it out a little as you go. So I worked with these 5 people, and I worked with existing service user groups and peer researcher groups that were based in homeless charities. And I went to them and said, this is something I'm thinking of doing. Would anyone be interested in? I then met with everyone one-to-one. We created individualized training plans, identified what things people were comfortable with, what things they weren't. And then we had this iterative approach of check-ins where every time we would work through something, I would have a one-to-one check-in afterwards and ask people, how did you find it? Would you like to do anything different? And we kept going along. And I think that built a really good trusting relationship, but also then meant people could say, actually, Emma, I'd like us to do this instead. And that's how we came across the visuals. It wasn't my idea by any means. It was a suggestion from one of the people I was working with, where they said they'd like it. And I said, I'm sure we can make it happen.
Perfect. We've had some work just shared in the Q&A for anyone's attention on reasonable adjustments to support attending appointments, which might be relevant for others who are working with a range of populations, to be honest. I had another follow-up question, actually. So you mentioned, I was really interested in this idea that sometimes we try and push service engagement too early or at the wrong time, and that this then potentially down the line prevents people from maybe being re-offered services. I wondered if you could talk us through some of your participants' ideas about how we can manage that process better.
Yeah, so I think what was really interesting is, in the context of the research, no one could tell me that, but I currently spend a day a week at an amazing homeless health drop-in center in Biker. And I think spending a day a week there, I'm starting to unpack a little bit more of that. And I think with some of it, it's around waiting for someone to come to you and telling people that, you know, there's these services here. I'm here to support you when you're ready for those services, and you're not alone. There is that support, but you get to decide when it is. If you reach a point where I'm really worried from a safeguarding standpoint, I will sort of try and encourage you into those services sooner, but almost having it more of an open dialogue and almost as a bit of an option. And I think having it as options and making people aware that those services exist and that you're there to support them means, you know, maybe that week they're not ready, but in 3 weeks' time, they recognize you and they'll go back and say, actually, I think I'm ready to have a conversation about that.
Brilliant, thank you. We have a question come through as to whether you have any data around the percentage of homeless people that are also aged under 25. And I mean, if you don't have that specific, just a reflection on whether there are maybe different challenges for younger adults or adolescents who are homeless.
Yeah, so I was going to say, I guess from a disclosure perspective, I tend to work with people over the age of 18. And I think as a result, those numbers tend to be slightly different. I think, if I'm honest, there's too many people who are experiencing homelessness irrespective of the age category. And I think there is very different needs, because often the way that services are commissioned are dependent on age categories. And often there's hostels and housings that are under 25, over 25, and it makes it harder to access services, but also it can make it more uncomfortable for people to go, in that if, let's say, you're 17 and in a hostel, trying to access a service with people that are 2 or 3 times your age, that can always be a bit frustrating in terms of accessing and how we go about accessing and comfort levels of how we access those services.
Fantastic. I'm good. There's 2 questions that I'm going to steal and offer to all speakers afterwards, but there are a couple of questions more specific to your work. So one question was whether you could speak a little bit more about what safe spaces look like or feel like for your participants.
Yeah, so I think this idea of safe space, someone sort of explained it to me as like, it's a place you walk in, Emma, and it just feels good. And I sort of said to someone, they're like, like when you are thinking of going into your favorite coffee shop, there's a reason it's your favorite coffee shop. It's because there's something about it that just makes you feel comfortable. You know you're going to get the services that you want and you're going to have a good experience. And I think people said that's all they're asking for with services. And so it meant having some privacy when they needed that degree of privacy, having a space that, didn't sort of look like it was, there was furniture all over the place. It looked as though it was intentional, but also I think a few people said they were kind of sick of going into places where they would see needles and other sort of substance use items all dotted around. They just sort of said they just want somewhere clean where they could go and feel comfortable.
Fantastic. I'm going to ask the other 2 speakers, if you don't mind, to pop your cameras back on, because there's two question themes here that I think I would like to kind of throw open for discussion, really. And the first one really was how receptive service commissioners are to the work that you've been doing, and if you have any good examples of that ongoing engagement. Perhaps Domenico, you could start us off.
Oh yes, what we did like very recently was to do some celebration workshops, which was in a way part of the EBCD methodology, in which we invited people from different walks of life, but also people who were involved in commissioning. So it's a conversation which is ongoing. There was obviously now the new changes from the previous system to the integrated care system, which obviously has to make us think as how these things are obviously included. I think there is, in terms of improving care for minority ethnic groups and for the people who can be socially marginalized, I think there is a strong willingness at the moment. It's just how to translate that willingness into actions that can be measured. But it's really like that. That's the challenge now, to go from the action plans to the practice. But I think there is interest in commission. So it's probably golden time now, but it's something that has to obviously translate into practice. As someone was saying, it's really important that we give back that what we have developed with the communities results into something that improves their lives. So it's not just an academic exercise.
Thank you. Patrick, have you felt similarly in terms of your work and how it's been received?
Yes, sure. So I've just noticed that increasingly commissioners are actually in these spaces. They want to hear the evidence that we're providing. But also on a personal level, I guess I will say that some of the findings on my PhD project have been used as part of the application for funding for some small scale projects. So, and the commissioners have really welcomed that. So I'm seeing that working alongside the community-led organizations has actually benefited them in terms of having an academic base, in terms of the funding needs, in terms of the research. And so, yeah, I just say yes. Sorry.
Yeah. Emma, any final reflections from your work?
Yeah, I was going to say, just highlighting that element of, I think it's not just talking to service commissioners about how to change services. I think also part of it is working with the community organizations with your research and going, this is what I found. How do you think this could work in your services? And then using that almost to feed back up. And I think there is appetite. I think there's obviously more appetite for lower cost changes. And so I think if you can have that sandwich effect of some easy wins or low hanging fruits, as well as some of those more ambitious dreams, I think that's probably a nice way to get people.
If I can add, I think we have come across some very interesting work done by some trusts in terms of community collaboratives, working with community groups to co-deliver care, or maybe like with particular groups to sort of provide some funding to these groups to reach kind of people who otherwise will be underserved. So I think there is the idea of working across different institutions is certainly attractive in this area, with the obvious challenge of working across different institutions or different organizations. But I think the future will be probably into integration of different agencies. Yeah.
That's a really good point. Thank you. Thank you all. I've got, I think, just enough time to offer a couple of closing remarks and signposts to ongoing discussion. I can't leave without flagging my question of the day. Unfortunately, I don't think we have any prize for this, but Florian's put a question that I think is probably unfair to throw at the speakers we have here today, but instead I would set this as a challenge for all of us who are working in research and practice here today. So Florian says, while co-production is great, how can the NIHR foster the integration of these demographics directly in our researchers? And I think that is a real ongoing and enduring challenge for us, and something that we have to take on as a personal challenge to improve. Just a couple of things that I've noticed across the talks today. Obviously, we could have picked from a wide range of work that's trying to tackle inequalities. And I think remembering that these are avoidable and unfair, we have to keep pushing to do more in this space. What struck me was that balance, I guess, between specificity and general approaches. We've learned a huge amount from these projects about just good practice, I guess, that should be just standard practice. It should no longer be good. It should just be what we do as a matter of course in terms of focusing on inclusion in our methods, in our services, and in our ways of working, and combining that with particular approaches that we know work well for particular groups where it's needed. I think that's really important. I think what was also nice to hear was just the efforts of the researchers involved to actually work in with and really be active within communities. I thought that was quite striking and is not something that we've always done well. So it's fantastic to hear that happening. Just to signpost some things that the audience members might be interested in next, we have the third and final seminar in this mini series on the 12th of July, same time, and this one will focus on showcasing some of the ARCs work on young people in particular. We've had discussions behind the scenes about just the level of interest that there has been around this social inclusion seminar. So if you would like us to see, if you would like us to pick up this and perhaps organise a more extensive programme of work or discussion in the future, please do let us know in your feedback forms. You will receive the slides, and I think we'll try and find a way to capture some of the questions and responses as well and ensure that they're circulated. But I would encourage you, as always, to reach out to the speakers. My thanks to Domenico, to Patrick and to Emma, but also to Lynn, Zoe and Nicola for your support behind the scenes organising this. Much appreciated, and we look forward to seeing you at the next seminar. Please do follow some of the wider communication channels about this seminar series and about the work more generally. Thank you all.